joining MCEDA for the next in our series of webinars. This one titled Public Health Reporting, Meaningful Use Stage 1 and 2. My name is Bruce Mackey, and I will be moderating today's broadcast. Sorry for starting a couple minutes late. It looked like GoToWebinar might have been having some sort of technical problems that was stopping folks from getting in, but we've seen that number steadily rise with people joining. So I think we're whatever was going on has resolved, and folks are able to join. But I apologize if you had any issues with joining the broadcast. Today we will be hearing from Laura Rapoli and Christy Brown. Laura comes to us here at Altarum Institute, the Deputy Director for the Center of Connected Health, and Christy Brown is a guest speaker from the Michigan Department of Community Health. She is part of the Meaningful Use Public Health Testing Support. A couple of house cleaning things. PDF is up. Okay. We at this point normally have the slides posted to our website, but there was a little bit of a delay on getting the slides up there. But the slides will be up there shortly, and possibly during the broadcast. When I get word, I'll let you know if you can go out and grab the PDF of today's slides. If and when they are up on there, you can go to mceda.org. Go to the Resources tab, and then go down to Webinars. And the PDF of these slides will be there shortly. And that's also the place to go to access any of our previous webinar materials, including links to recordings. This broadcast will also be recorded and posted to the website shortly after the conclusion of today's broadcast. So if you want to go back and listen again, or perhaps pass it on to anyone else who wasn't able to join us, please feel free to do that. I will begin today by going over a brief overview of MCEDA and Meaningful Use. Oh, one other thing, if you have any questions throughout the broadcast, we will keep the lines on mute as we usually always do, but please use the GoToWebinar interface to type any questions you might have for our speakers into the questions or chat window of your GoToWebinar interface, and following the presentation, we will take some time to answer any questions that come in. So again, I will be going through a very, very, very brief overview of MCEDA and Meaningful Use. I'm going to keep that very short. You've all heard our spiel before if you've joined us, and I want to make sure that we leave enough time to get to the meat of our presentation, which is talking about the public health objectives and the steps to meet the objectives in both Stage 1 and Stage 2. So with that, we'll move on. Let me talk just a little bit about who MCEDA is. I know we do have a handful of folks that are not MCEDA clients or names I haven't seen before in the registration list. So I'll go through a quick spiel about who MCEDA is. We are the Michigan Center for Effective IT Adoption. We are one of 62 ONC regional extension centers that were set up back in around 2011 at the beginning of the program. We're funded as part of the HITECH Act to basically help providers reach meaningful use. Our purpose here is to support the triple aim of improving patient experience, improving population health, and reducing costs by tackling these 5 different performance measures you see on the graphic on the right of your screen. Improving quality, safety, and efficiency, engaging patients and families, improving care coordination, improving population and public health, which is a big part of why we're here today, and ensuring the privacy and security protections of your private health information. MCEDA services are highly subsidized, especially on the meaningful use side, and mostly for Medicaid, those in the Medicaid program now. But we are here to help with all stages of meaningful use. Doesn't matter what stage or year you are in, MCEDA can help guide you through that program and provide expert advice and best practice, and kind of just basically walk you through beginning to end, A to Z, in meaningful use. All stages, all years. We have a security risk assessment, which is part of our meaningful use support, but can also be broken out as a standalone service offering if that is all you are looking for. We also offer something called targeted process optimization, which is takes a lean approach to any number of practice improvement initiatives you might be looking to undergo or in the midst of undergoing. Basically, if you're having a problem and need to tighten things down in your practice, or have any issues and would like our help, we are here to help guide you through that, and have some experts on staff here who can provide a great deal of expertise in any number of practice improvement initiatives. Also, attestation and audit preparation. If you are one of the lucky folks that are being selected for an audit and want to ensure that that you have all your ducks in a row and have done everything properly to meet meaningful use, we'd be happy to look everything over for you and guide you in that. Also, if you're just getting ready to attest, and again want to make sure that you have everything in order before you go forward and attest with meaningful use, we would be happy to help you with that as well. Very super brief overview of meaningful use. Meaningful use as defined by CMS is using certified electronic health technology to improve quality, safety, efficiency, and reduce health disparities, engage patients and families. That is a big part of Stage 2, which a lot of folks are rolling into with making better use of your patient portals. Improving care coordination and population and public health. Again, a big part of why we're here today and what we're talking about today. And maintaining the privacy and security of patient health information. Ultimately, if and when the meaningful use program is fully successful, we've seen a lot of success thus far, but we have a long road to go yet. We should see better clinical outcomes, improved population health outcomes, increased transparency and efficiency, empowered individuals, and a lot of robust research data on health systems. Most of you have probably seen this graphic over the past few years, but just real quick, wanted to touch base on kind of the progress of the stages of meaningful use. There are 3 stages of meaningful use. Each provider attests to meaningful use for a minimum of 2 years. Although some folks, even some on the line, ended up doing 4 years of Stage 1 with some of what happened last year with the Flex Cert rule. But a lot of folks are rolling into Stage 2 this year finally, which sees, at each level or each stage of meaningful use, the bar is raised. The objectives get a little tougher. The thresholds that you need to reach increase significantly. And there are, moving from Stage 1 to Stage 2, there are also new measures and objectives as well that you have to meet. Stage 3 is still a work in progress. We've heard that things are moving forward with a Stage 3 final rule. It's in a budgetary office right now in our government, and we hope to see a Stage 3 final rule sometime later this year. And we're all eagerly awaiting to see what Stage 3 is going to look like. Moving from Stage 1 to Stage 2, just a quick snapshot of what each stage entails. In Stage 1, eligible professionals were working on 13 core objectives. We're choosing 5 of 9 menu objectives for a total of 18. In Stage 2, changes a bit, where you have 17 core objectives that you're on the hook for. You are choosing 3 of 6 menu objectives for a total of 20. That is a very high-level look of meaningful use. I want to now turn things over to Christy Brown from the Michigan Department of Community Health, who will talk about Stage 1 public health objectives. Christy?
Hi. Thanks, Bruce. Good afternoon, everybody. As Bruce mentioned, I work in the Michigan Department of Community Health. I am a departmental analyst here, and in this role, I function as a liaison between the EHR incentive program staff and our public health agencies, and I also provide support for our providers in their quest to meet the public health meaningful use measures. And I've been asked to talk a little bit about that with you today. So as Bruce had mentioned, and you're probably all aware, meaningful use consists of both core measures and the menu measures. And the core measures are all required. You have to report on all of those. But in the menu measures, you must report on at least 5 of them. And of those 5 that you are reporting on, at least 1 must be a public health measure. And in Stage 1, there are 9 menu measures to choose from, and 3 of these are public health measures. Next slide, please. The 3 public health measures available in Stage 1 are submission of immunizations, submission of syndromic surveillance data, and electronic lab reporting. All three of these public health measures are available for hospitals to report on. However, only the first two, immunizations and syndromic surveillance, are available for eligible professionals. So eligible professionals attesting to meaningful use should make sure that they select and report upon the submission of immunizations or the submission of electronic syndromic surveillance data. Next slide, please. Now, there are some circumstances under which it's not possible for a provider to report on a public health measure, and CMS recognizes this, and they've established some exclusions that can apply under certain circumstances, and those circumstances are listed here. But providers all need to be careful about these exclusions because they're not all valid here in Michigan, and it's very important that you understand which ones are available to use here in Michigan and which ones are not. For example, the third exclusion listed, that the public health agency does not have the capacity to receive the data, is not a valid exclusion here in Michigan. Each of the public health measures is supported for stage 1 in Michigan. And it's also important for those providers who do not immunize to know that you are not necessarily excluded then from the public health measures. Syndromic surveillance is available and is open in Michigan and has been since August of 2013. So providers who do not immunize should seek to complete the syndromic surveillance measure in order to complete the public health requirements for stage 1. It's not uncommon for us to see in our Medicaid section attestations from eligible professionals that come in and they're failing to meet meaningful use because they did not properly complete the public health measures. And it actually just happened yesterday. We had to fail a provider for meaningful use because they did not realize they were required to complete syndromic surveillance as they were a provider who did not immunize. But the last exclusion option listed here explains a few certain provider types for which the syndromic surveillance system here in Michigan will not accept data from. They're highlighted in the box at the bottom, and they include dentists, dental surgeons, optometrists, ophthalmologists, chiropractors, podiatrists, and certified nurse midwives. So if you are one of those provider types and you do not immunize, it is possible for you to claim exclusion to the public health measure for the attestations here in Michigan. But if you do immunize, if you're not one of those provider types, then you must make sure that you're reporting on one of those measures. Next slide, please. I think probably one of the reasons that providers are so confused about whether they can claim an exclusion in the public health measures is because they really don't have an understanding of what syndromic surveillance is. So we'll cover that a little bit here. Syndromic surveillance, syndromic data is a set of de-identified data collected from emergent care and ambulatory care settings used to detect bioterrorism, emerging infections, and outbreaks. And in Michigan, the important piece of data that's collected is the chief presenting complaint. The Michigan Syndromic Surveillance System, or MSSS, collects and tracks the chief presenting complaints from healthcare providers, and this allows the public health officials to monitor trends and investigate unusual increases in the symptom presentations. So in my understanding, in general, the chief presenting complaint is collected at every patient visit, and therefore nearly all providers will have this information and can be participating with the MSSS on the syndromic surveillance measure, unless you happen to be one of those provider types that we mentioned previously. Next slide, please. So what if you are one of those provider types, the dentists, optometrists, and such, and you don't immunize and you're not eligible to submit syndromic surveillance data? How do you complete the menu measures in that case? If you have a valid exclusion from both of those available public health measures for EPs for stage 1, meaning the immunizations and the syndromic surveillance, then there are two ways that you can complete the measures. You can either report on 5 menu objectives that are outside of the public health measures by meeting the measure, or you can claim an exclusion from one of the public health measures, either the syndromic surveillance or immunizations, just one of those, and then report on 4 other measures, but You can only do this if you can justifiably claim exclusions on all of the other measures. And this sounds a little bit confusing, and it is. So if you ever have questions on this, you should make sure that you contact us here at DCH or your contact at MCEDA to make sure that you understand when you can do that. And always remember to keep supporting documentation in the event of any audit. So in a short way to explain it is you can't use a public health exclusion to count toward the 5 measures unless you can justifiably claim an exclusion for pretty much every other measure. And if you're attesting to the Medicaid EHR incentive program, our system will not allow you to submit the attestation unless you follow these guidelines. And it's also going to require you to report on a public health measure, either by way of exclusion, if you're one of the provider types who can eligibly claim the exclusion, or by reporting on the measure. Next slide. I think another topic that providers seem to be confused about are the public health agencies here in Michigan and their acronyms and what data they collect. So we'll briefly go over those. Immunizations get submitted to the Michigan Care Improvement Registry with the acronym MICR. Syndromic surveillance data goes to the Michigan Syndromic Surveillance System, or MSSS, and reportable labs, which are only available for hospitals, are handled by the Michigan Disease Surveillance System. Providers seem to be particularly confused between MSSS and MDSS, and I think part of that might be with the word disease in the Michigan Disease Surveillance System. I think that can confuse providers because it's similar to a syndrome, but MDSS is for electronic lab reporting and is only applicable to hospitals. So EPs need to be concerned with the MSSS, or Michigan Syndromic Surveillance System, for their syndromic surveillance submissions. Next slide. Okay, so now that we've covered the options for public health measures in stage 1, we'll go over what's required to actually meet the measure for the first year of stage 1 for the public health measures. The first year is the basic 1 test requirement. In your first year of meaningful use, you must submit at least 1 test message prior to the end of your meaningful use reporting period. There are certain requirements that the test must adhere to with technology standards, and the EHR must be certified for that public health measure. But the test does not have to include actual patient data, and the test does not have to be successful in order for you to meet that measure. However, if the test is successful, you should seek to establish regular reporting with that public health agency in accordance with applicable law and practice. Next slide. In a multiple provider group setting, this can be all accomplished together with 1 single test or onboarding effort across locations, provided that the locations are all using the same certified EHR technology and they share a network for which their organization has the operational control over or the license to use. This is noted in this FAQ here by CMS, and this makes it much easier for the groups to complete the testing. Before, this was added by the stage 2 final rule, I believe, and before that the locations all had to test separately, but this FAQ allows them to all use the same test message to count for all of the EPs across the locations. Next slide. So for those providers who have never completed the testing before, you're probably wondering how you should go about this, what steps you should take. The first step listed here is to ensure that the provider or the providers are all registered in the Health System Testing Repository, or HESTR, which is Michigan's registration and tracking system for public health reporting. This is a web-based registration system, and the address is listed here in the first box. There are instructional tip sheets available at that site for directions on how to submit the registration. Once you've registered, a representative from the Public Health Agency will review your registration and contact you by email to provide confirmation of the registration and then provide test submission instructions. Please allow some time for this to happen, up to a week or two, depending on the time of the year. The email will be sent to the person identified as the primary contact for the organization in the registration. Make sure that you read the instructions provided by the Public Health Agency in the email and follow those instructions to submit your test message. Once the Public Health Agency receives your test message, you will receive a letter via email to that same email that you had submitted in your registration confirming the submission of a test message. And again, please allow a week or two for this process as well. And when you get this letter, hang on to it. This letter will be your evidence in the case of an audit. Next slide. So that's what's required for the first year of Stage 1 of meaningful use. But there are 2 years required for Stage 1 of meaningful use, and the second year of Stage 1 meaningful use requires follow-up submission. The follow-up submission process can be a little confusing, both for the providers and for us here. Be sure to contact us again if you have any questions. Don't make assumptions. But here are the basics. First of all, it's not acceptable to use that same test that you had used from the first year to meet the measure for year 2. You must take additional action. And the action taken can be in various forms, but at a minimum it requires engagement with the Public Health Agency. That engagement and action can be in the form of regular reporting. Like as noted previously, if your test in Stage 1 was successful, you should seek to establish regular reporting with that Public Health Agency. So that regular reporting would qualify as follow-up submission. Engagement could also be in the form of additional test submissions. Or it could be in the form of simple communication. If this is the case and you're not planning to do another test, though, you would need to demonstrate first of all, that another test is not beneficial, and then also that follow-up submission was not possible, which is probably not likely to be the case, especially with syndromic surveillance here in Michigan. I know that MSSS would really like to see additional messages for that second year and begin that quality validation process moving toward production. It's also very important to note that Medicare auditors are requesting proof of engagement during that second year of meaningful use. So the action must be taken during that time frame. And retain evidence of this action. If it's another test submission, hang on to your acknowledgement or your validation report. If it's in the form of communication, then make sure you keep the email so you have that evidence. Next slide. Here is a layout of the basic steps to complete the follow-up submission requirement for Stage 1, Year 2 for immunizations, syndromic surveillance, and reportable labs. The steps to complete the second year of meaningful use are a little bit different depending on the Public Health Agency you're working with, but the basic steps are similar. Send an email to your Public Health Agency and follow up. For immunizations, you should email the MICR Help Desk, and the email is listed there in the first box. And state your intention to engage in follow-up submission process and follow the data quality assurance process from the MICR website. For syndromic surveillance and reportable labs, you should send an email to the DCH Public Health mailbox, also listed in those boxes on the page, and state your intent to engage in follow-up submission and follow the data quality assurance processes. And in all cases, keep your letters of confirmation, as this will be the documentation used to support your work in the event of an audit. And that goes for all meaningful use documentation. That's all I have. I think next slide, Laura will be discussing the public health objectives and requirements for Stage 2. Thank you.
Thank you, Christy. I appreciate it. Yeah, with that, we'll turn things over to Laura Rapley, who will discuss the Stage 2 public health objectives.
Okay, thanks, Bruce. We'll first take a look at some of the differences in the objectives between Stage 1 and Stage 2, what's new and what's different. So with Stage 2 for eligible professionals, there happens to be 4 selections for public health measures, and 2 are new: cancer case reports, capability to identify and report to a registry is new, and the specialized case reports, capability to identify and report specific cases to a registry are new. And in Michigan, Michigan is ready to receive specialized case reports and cancer case reports. The difference with the hospitals is for Stage 1 hospitals, all the public health measures were a menu item, and now they have moved into the core, meaning it's not an option to select a public health item. For Stage 2, it's actually required. For eligible professionals, immunizations moved up into the core objectives, and providers do need to submit immunizations if they administer immunizations. And syndromic, cancer, and specialized registry are all menu objectives. So as with Stage 1, there are some exclusions that were laid out in the final rule for the public health measures, and some of them don't apply to Michigan. So if we go through them, an eligible professional or hospital that does not administer immunizations during the reporting period is feasible, and you could claim an exclusion if you did not report immunizations. An eligible professional who does not collect reportable syndromic data or diagnose and treat cancer or the disease associated with the specialized registry, you could claim an exclusion if you fall into that category. A hospital who does not have an emergency or urgent care department would not have to report syndromic and could claim an exclusion. However, the next 4, in Michigan, the public health systems are ready and available. So the capability of accepting specific standards required by the certified technology, all of our public health systems are able and capable of accepting the information that's required by the final rule for the standards. And also, it's not a valid exclusion if an EP operates in a jurisdiction where no immunization registries or public health agencies provide information timely on their capability to receive the information. We are ready and available in Michigan, and it is posted on michiganhealthit.org. So that information is available. And a hospital operating in a jurisdiction where there's no immunization or public health agency providing information in a timely manner that they're capable of receiving, it's the same. Michigan Health IT has our declaration of readiness for all the public health systems, so that is not a valid exclusion. And also, an EP or hospital operating in a jurisdiction for which no public health agency is capable of accepting specific standards at the start of their EHR reporting period, you wouldn't qualify for an exclusion in Michigan on those grounds because we are ready to receive them. If it was prior to August of 2013, that could be an exclusion for syndromic, but syndromic became available in August of 2013. And of course, with syndromic, we have the list of providers, eligible professionals that they are not accepting data from. Next slide. So the Michigan Department of Community Health supports all of these systems. As Christy mentioned, we have MICR for immunizations and Michigan Syndromic Surveillance System for MSSS, And for reportable labs for hospitals only, we have MDSS. And then new to stage 2 is the Michigan Cancer Surveillance Program. And cancer case is a mandate for hospitals and physicians to report cancer case information. So you would be meeting a measure and also meeting the public health mandate to send in cancer case information. And then for our specialized registry, Michigan has a birth defects registry and is ready to receive specific cases on birth defects. And it also is a public health mandate that hospitals and eligible professionals do report diagnosis of birth defects. However, the specialized registry, again, is just for eligible professionals right now, not for hospitals. Next slide. So with stage 2, there is 2 years. However, as in stage 1, there are 2 separate things you need to do for each year. In stage 1, or stage 2, there's actually 4 different scenarios in which you can attest to saying you've met the measure. The first scenario is really related to if in stage 1 you already were reporting electronically according to the regulations to the public health system. So for example, with MICR, the immunization registry, if in stage 1 you were already in production, sending your immunizations electronically and not having to hand key in the information into the web-based application, you could attest, yes, that you're meeting the stage 2 measure because you already achieved this in stage 1. Stage 2, or scenario 2, 3, and 4 all require registration of intent. So you go to the website, and we have more information on that, and Christy mentioned it, the Health System Testing Repository. We have the URL that you go to in this slide presentation. But that's new. This is new to stage 2, that it's actually in the final rule. In stage 1, it's a Michigan requirement just to track your meaningful use. It's not part of the measure. In stage 2, this is absolutely part of the measure. You must go and register your intent to submit ongoing submissions to the public health system. Scenario 2, once you've registered your intent, if you've achieved ongoing submission, you're in production during your reporting period, you meet the measure. Probably not possible with the 90-day reporting period. However, with the whole year period coming up here in 2015, that would be a possibility. And we're finding that scenario 3 is where most providers and hospitals fall into, and that's registering their intent with 60 days and then being engaged in testing and validation process. So that's the scenario that we're finding most of the providers and hospitals are falling into. They keep going from follow-up submission to continue their testing and validation. Scenario 4 doesn't apply in Michigan. It's registering your intent and then awaiting an invitation to engage in the required testing and validation process. Well, actually, when you register your intent, you receive an invitation to be engaged in testing and validation right as you complete your registration. So next slide. And there are 2 possibilities that you could fail to meet the measure in stage 2. And as I mentioned, you have to register within 60 days of your reporting period. If you do not, they are checking, and you could fail to meet the measure. So make sure that you're going to the registration site and registering. And then the other scenario for failing to meet the measure would be when you are involved with your onboarding process or your testing and validation, and the syndromic team or the MICR team or the cancer team asks an action of you. For example, you've submitted a test message and it didn't quite meet what they expected to receive, and they ask you to submit again, and you don't comply or you don't resubmit twice within 30 days, the public health agency, they can track that, and then the auditors can take a look, and if you have not followed up with their action within 30 days on 2 separate occasions, you can fail to meet the measure. However, I will say that the public health systems currently are not proactively doing this. They understand that the 2014 upgrading to its 2014 certified product has been a lot of work, and it's been a lot of work on the public health agencies just to accept the registrations and work with you all on testing and validation. So at this point, there isn't a public health system that's acting upon this, but not to say there may be in the future. Next slide. So the failing to meet the measure as it relates to the onboarding process, what is meant by onboarding? So it is the testing and validation, and what it does is it ensures that you have entered the required public health information into the EHR. There are implementation guides that your vendors have and they needed to comply with to be certified. So we're checking to make sure that the information required for public health reporting is actually in the system and that you can capture it, enter it, and generate it. So it's also checking with the public health agency that they are receiving the information they need to receive for their surveillance activities in order to do their surveillance before they add it into their system, and we call this whole process data quality assurance. Next slide. So here are the high-level onboarding steps, and each system has detailed steps that are emailed to you. But at a high level, step 1 is learn about the reporting requirements, register your intent, test and validate, and establish a transport method, send production reports or messages, and monitor for data quality. And I believe the next slide is so learning about the requirements, step 1. As Christy mentioned, you visit Michigan Health IT. Here is the address for the registration site. Excuse me, at the registration site, but in general for information about all of the public health systems. It contains FAQs. It contains the contact information on who to contact with questions on the different public health systems. And it has those implementation guides that the EHR vendors and your technical support use to enable you to submit to the public health agencies. And then, of course, it does contain the link to the registration site. And sharing the implementation guides with your vendor or technical support is really important. There are some detailed information in these implementation guides on how, for example, how to transmit or send the message. And next slide. So step 2, registering your intent. I know we keep going over this, but because it's a part of the final rule now, really want to make sure you're prepared and you do register your intent. There are tip sheets on the website before you start to register. You can register as an individual, There is a group registration process there. Once it's complete, the invitation is right there. The language down below is your invitation to start submitting. So therefore, that's the reason why that exclusion is not valid in Michigan. And next slide. So frequently we ask question. In Michigan, we expect stage 1, when you're in stage 1, to go to register to the same site that for stage 2. So would everyone, eligible professionals that have registered in stage 1 for immunizations and syndromic need to go back and re-register for stage 2? And the answer is no. You do not have to go to the site if you've already registered in stage 1 for syndromic or immunizations. What you need to do is you need to email the MICR help or Christy and let them know that you have entered into stage 2 and that you are actively engaged in testing and validation. And next slide. And what is testing and validation? That's scenario number 3, where you can meet the measure and be in testing and validation. It is a process for data quality assurance to make sure that the information that the public health agency receives is what they need. So you submit the messages or the reports in accordance with the implementation guide, and the public health team will evaluate for data quality, and then the public health team provides feedback to you. And what you would be expected to do is there are reports that tell you what to do, and you would remediate any issues, and then resend another report, and then it goes around for another cycle where the public health agency evaluates and provide you feedback, and it's kind of a circle until everything's in order and there's a good message or a good report that the public health agency could consume and use. And next. And for scenario 3, if you're not already in production and sending messages, you would need to connect to a Michigan Health Information Network qualified health information exchange. All of the public health reporting goes through the MyHIN, and there is the address for the MyHIN and information about the different health information exchanges in your area. You select a health information exchange, and they connect you. There's a pipe to get your information to the public health agencies. You follow their instructions, and then you can submit information. Next slide. So when you're finally through the testing and validation, and you have what the public health agency needs, you want to continue and make sure that your EHR is set up to transmit the information on a regular basis, and respond to any requests from the public health team. They're still evaluating your data as it comes in once you are in production, and they will be contacting you if they find any data quality issues, and so you would be expected to correct those issues. And then, of course, keep a record for auditing that you are in follow-up submission, ongoing submission. Next slide. I think that's it.
All right. Thank you very much, both Laura and Christy. We want to open things up and take a little time to answer any questions that everyone might have. We've had a couple that have come in during the presentation. We'll start with those ones. But as I mentioned in the beginning, if you have any questions for Christy and Laura, please type those questions into the GoToWebinar interface, into the questions or chat window, either one. and we will address them before we sign off today. First question I will answer, it is, are we able to print the presentation or will it be recorded for others that could not attend today? Both, actually. I have received word that the PDF of the slides is available now on the MCEDA website. So if you go to mceda.org and navigate to the Resources tab, go down to Webinars, the PDF of today's broadcast is already there, as well as all our past PDFs, all our past webinars are archived there. And within a couple of days, anyway, there should be. If you come back to this same page, you will see a link to a YouTube site that has the recording of today's broadcast there as well. So again, that is mceda.org, the Resources tab, and then navigate to Webinars. Next question is, our EHR vendor is telling us that they do not offer syndromic surveillance interfaces because the CDC has yet to come out with the messaging guidelines for ambulatory care. Is this accurate information? I would say, Laura, what do you think on that one?
There actually is a standard for syndromic in the final rule, the ONC final rule, and it is a part of certification. So there are EHRs that are certified for syndromic surveillance, and the first requirement, if you want to select syndromic surveillance, you need to select a EHR that is certified for syndromic, and if they are certified for syndromic, they should be able to generate a syndromic message. I don't know if that.
Yeah.
Christy has anything more to add to that?
I'm not sure that the final rule addresses the transport for ambulatory. I think it addresses the structure, but I don't think it addresses the transport. But I'm not 100% sure on that.
What's the question, transport?
No, just says
No, they should be.
Yeah, just says that they don't offer it. They don't offer an interface because the CDC has yet to come up with the messaging guidelines.
No, there is a guideline, and it is true that transport is not a part of the final rule. It's up to the public health agency to decide how to send public health data, and Michigan has chosen the MyHIN.
Yeah, for the person that asked that question, I think you most definitely can push back on your vendor, because there are many vendors that have syndromic surveillance interfaces up and running. So they've been able to figure it out. There's no reason why any other vendor can't as well. Next question. Are there currently any known EHRs in Michigan that are unable to connect with MICR or any other surveillance systems? There's a second part of that is the data flow continuous and unidirectional or bidirectional?
So MICR.org lists the the EHR vendors that are in production. So we could probably provide that link for you at a later date. Exactly, and it lists all of the EHR vendors that are in production, and there are several. And for the meaningful use measure, it's just unidirectional, meaning it's from your EHR to MICR. There is talk of stage 3 being bidirectional, where you could actually query for a child's immunization record from your EHR and MICR would send it back to you. That's not a part of stage 1 or 2, and it's being discussed for 3.
Okay, thank you. We have one more question so far, although we still have a couple of minutes, so if anyone else has any additional questions, please get them in before we end the broadcast. Next question is, for stage 2, there are 4 public health selections. How many are required to achieve meaningful use stage 2, and will stage 3 require more selections? So in stage 2, there is no mandate that you must select the public health measures. In stage 1, you do have to select one of your at least one of your menu objectives has to be a public health, but that is not carried forward into stage 2. So you are not mandated to select a public health measure. Although certainly, if you've gone through the steps in stage 1 with either MICR or syndromic, we encourage you to certainly continue on that path and move forward into ongoing production.
Yeah, there are 6 menu items for eligible professionals. 3 happen to be public health, and but as Bruce said, it's not a requirement in stage 2 to select a public health measure.
Okay, well with that, I don't see any other questions coming in. Take a moment to thank everybody for joining us today. I hope you found our discussion helpful and useful to you. There's a couple of websites up on the page here. I think the first one, that michiganhealthit.org/public-health, is a great source to go to with any questions you might have. I also have both Laura and Christy's email addresses here. And you know what? We had one last question come in under the wire. Let me ask this real quick, and then we'll sign off from there. Question is, can you please explain DQA requirements a little bit more? Can you do that in 30 seconds?
Each public health system has a set of criteria for data quality assurance, and so we could provide you with the guidance. You are given the guidance for data quality when you are sent the email that you're confirmed, you're registered. You will receive instructions on that, and each one has separate data quality assurance guidelines. They have tip sheets that we could make available for that. They are a little bit different for each type of data coming in. So that will we can send out the tip sheet.
Okay. All right, thank you. Thank you, Laura and Christy, for the informative presentation, and I thank everybody for joining us today, and I hope you all have a wonderful afternoon.